Welcome to people in the room and welcome to people online. Thank you for joining. This is actually our third public health grand rounds. So I'm Alicia Nolan. I'm the state epidemiologist. So I came to do this job, gosh, it's almost 4 years now, very close to 4 years. And one thing that I was noticing as a state epidemiologist is we have tons of data, we have tons of information, but we tend not to get it back to our clinicians super well. And so this series is my attempt to try to get information back to clinicians. It's supposed to give you information about what we're watching at the public health level, at the health department, so that it can be in your brain as a clinician and affect what you're doing as a practice. So this is the third one we've done. And what I try to do is every time I do one of these is do one chronic disease topic and one infectious disease topic. So nobody feels cheated. So today, talking about colorectal cancer and measles. And as you might guess, like measles was a no-brainer. I had to do measles, right? Like that is the topic.
Because measles cause colorectal.
No, they're not related, but it was obvious that you talk about measles right now. So that will be the main topic, two topics for today. But first, I'm doing what I'm calling public health vital signs. So instead of heart rate, blood pressure, we're going to be looking at some diseases that really we always monitor in public health. And I just will really quickly go through them and let you know what's happening in the state of Utah. So first, seasonal respiratory viruses, the thing we always dread. So the three that I specifically think we all care about is RSV, flu, and COVID. So looking at what happened this past respiratory season, we actually did in general. So on the top, you can see RSV, and it's going from the season 2019-2020 all the way up to 2024-25. So 5 years ago to this past season. And you can see RSV, we actually had a pretty good RSV year. If we go down to the bottom, COVID, it also was a pretty good COVID year in terms of hospitalizations and deaths. Flu was the outstander this year. We did have quite a bit of flu hospitalizations and deaths this year in Utah. That was true across the country. So I think probably all the clinicians remember 2 years ago, we had the horrible RSV year. You can see that there. We didn't have that this year, but we had flu. Other one I want to highlight is the STIs. So chlamydia, gonorrhea are two leading STIs. You can see again from 2019 to this year, this is actually just the calendar year for each one. So up to this point in the year for each of those years. So it's only part of the year, but it's equal for all of them. So it looks like we're actually pretty standard for chlamydia this year. Gonorrhea, maybe we have a little bit of a decrease, but I always have to say 2021, 2020, 21, 22 were weird years. So we are maybe quite on what we would expect right now. Shigella and norovirus are two big GI illnesses. We look like this year we actually were reasonably high in our Shigella cases. This tends to be a seasonal infection, so we are expecting it to increase as the summer comes on. But right now we are in that high level for the year. Yep.
How do you guys get your data for this?
So you should listen to 2 lectures. So we have what's called electronic lab reporting. So the state automatically pulls all clinical laboratory data from across the state. So every hospital system, every clinical lab has it, so they automatically ship us data for our reportable conditions. And it's about 89 reportable conditions we have, so we automatically get the data of any positive test for those 89 conditions. Norovirus is not good. Very true. You are right. So norovirus is the one that is not reportable, and you see what I have below there is outbreaks. And that's because you're right. We don't know how many people tested positive for norovirus, but we do know how many outbreaks there were because we get called when there's an outbreak in a school, a nursing home. You can imagine all those congregate kind of sets. We get calls for it. So Shigella, number of people tested in state and positive up until this time of year for all the 2020 to now. We're pretty on par for where we were. We might have a highish year. Norovirus, we definitely had a high year in terms of outbreaks. And I think we all saw that in the media. And I bet you saw that in the emergency room. I will say that is now done, at least from what we're seeing, that we are not getting calls about outbreaks of norovirus.
These are from stool samples, I'm assuming that they're doing guidance time. A lot of these people have stool samples.
So there is no question our data is limited to the people who were tested. So if people come in and get a clinical diagnosis, for these type of infections and diseases, we don't get that information. There are some diseases and some ways that we collect information when it is a clinical diagnosis, because we can look at ICD codes. So it depends on exactly which disease we're talking about, which one we do. We usually look more for trends at testing data because it's more stable. We know it's a higher quality data, whereas ICD codes, I know when I was a doctor, it was like you type in the first few letters and then you're like, that looks right. So we know ICD codes are a little less. So yes, Shigella, high-ish year, but not crazy. Norovirus, definitely a high year, but happily that seems to be past us. And then the two that I wanted to put on that are high concern diseases are TB. I've heard from many clinicians, especially at the U, that they are seeing so many TB cases in the last few years. And our data definitely shows 2024 was a bumper year in terms of TB cases. This year, we might be back to what is more of our standard. We are, of course, less than halfway through the year, so we'll see how that plays out. On the other hand, syphilis, we continue to see the high rates of syphilis. And what I've pulled here is specifically focused on women of reproductive age and congenital syphilis, because that's the syphilis we're most concerned about. So really the two relate to each other. You can see we are having a lot of women diagnosed who are in their reproductive years. That is actually a newish trend. It used to be syphilis was considered mostly transmitted in men who have sex with men. We're seeing it much more in women these days. And that leads to the second graph, which is congenital syphilis. We had a number of years with zero, but unfortunately we are having more and more each year. And this year looks like it could be quite high. You will see I don't have the numbers on the y-axis for the congenital syphilis. It's because it's happily very small numbers. So we try not to put out those exact numbers. But the trend is clear. We have more than in any of the last 5 years.
Is that one of the automatic testing?
Yep.
So they all test.
They all. It's for pregnancy when you're for new. Yes. So there's routine screening. Every woman's supposed to be tested at the very first prenatal visit. And then there is recommendations to have actually 3-point testing. And it depends exactly where you are in the state. It's related to how high a prevalence there is in your area. Whether or not you are recommended to have the 3-point testing during pregnancy or just 1 point. No, they do not. In case you don't, the syphilis testing is one of the most messy testing system. It's just not an easy test, right? To interpret is so painful. So overall, what does our vital sign look like so far? In general, we have a lot of, okay, it's a reasonable season. We definitely had a bad flu season. We definitely had a bad norovirus season, but those are past us now, which is great. But what we are seeing right now is probably a high Shigella season and a high syphilis season. So quick wrap on those just to make sure people are aware of what's happening. And now to get to one of the main topics, which is colorectal cancer. And I'll admit, I picked this because I've read so many different things talking about trends in colorectal cancer and concerning trends in colorectal cancer. So I assume many other people in Utah have looked at that, and I thought it would be useful to talk about the trends overall, but also what's specifically happening. So first, colorectal cancer is the second leading cause of cancer deaths. So this is not a minor player. It's right after lung cancer. And in the projections for the year, when they look at last year's estimate, we expect there to be 154,000 people who will be diagnosed with this and 53,000 people who will die in the United States, not in Utah. So this is significant. But happily, we have been doing well with this disease. This is the number of people who've been diagnosed with colorectal cancer in the United States since 1991, and it goes to 2021, and you can see a nice time. So that's what we want. We want it to come down. That's United States, and here in orange is Utah. You can see we consistently have had lower rates of colorectal cancer, but we generally follow the same pattern. So we look like we're having the same decrease, which is great. When we look at us compared to the other states across the country, we actually are in the lowest quartile. So we're in the lower 25% of states in terms of how many people get colorectal cancer in our state. But of course, any of it is bad, right? We want to make sure this does not kill anyone. So who exactly is at higher risk of colorectal cancer? Well, the one that stands out very clearly is men. Men have an incidence of colorectal cancer that's 27% higher than women. And the rate of death is 42% higher than women. So it's not just that they get diagnosed, it's that they get diagnosed with a severe disease that can go on to kill them. So you can see on the top with the solid blue bars, the male incidence is highest, but it is coming down just like the female incidence. And then the lower two lines are male for mortality and female mortality. And you can see those also are decreasing, though maybe at not quite as steep, but it is decreasing. So yeah, men are at higher risk. Older people are at higher risk. There is no question as you get older, this is your biggest risk factor. Why you will get colon cancer is because you get older. And it is notable that there's a very dramatic increase there, but there's no clear cutoff, right? It isn't suddenly you turn 50 and it goes up. No, it is even present in the younger ages. And then last, people of color. Here in this graphic, the people who are white is the middle blue bar, and you can see that there are both in the American Indian, Alaska Native, and the Black population have higher rates than the white population. So definitely there is a contribution there. So that's general data from across the US. So here in Utah, we really do see the same kind of pattern. So the blue is incidence, where the yellow is mortality. The solid line is men, and the dotted line is women. So you can see, like other parts of the country, we are having a decrease over time, but we do see a higher incidence and mortality in our men.
Why? No, I was just going to ask, why is it decrease?
So,
Like, that's what we're going to ask.
yeah, so there's a lot of, it's like getting people in for screening, right? Getting them screened and get the polyp out before it goes to cancer. That's probably the biggest one that we know of. There is possibly some things with decrease in smoking rates, right? Smoking definitely has a contribution here. That probably is likely related. But then there's mixed things which you think might counteract it, which is diet. We know that diet has a big impact in colorectal cancer. So you almost have thought it would have gone up from that. But I think most people will conclude this is mostly due because of pretty aggressive screening approaches. Yeah. Overall, looks great, right? So that's the big picture. But now let's go into the details where maybe it's not quite as great. So if we look into trends a little bit more deep, and we look at both incidence and mortality, and we pick it out by age, turns out people who are over 65, good. They are definitely decreasing, both women and men, both in terms of incidence and mortality. However, that's a little different when we look at people's 50 to 64. You can see we had a good decrease, and then it really looks like we're plateauing. So we seem to have stopped getting better at this in that specific age group. And then most concerningly is our people 20 to 49. We are definitely seeing an increase in this population, both in terms of incidence and mortality. So the wrong direction, right? So I had this, if you don't look at the mortality, I had this whole debate in myself, well, maybe it's because of our more aggressive testing, we're like diagnosing people differently, and that's why we see the increased incidence. So I looked into that. It turns out, no, it's actually these people who are young are actually being diagnosed with pretty advanced cancers. It isn't that they're being diagnosed with localized cancers. So as you see, the top one is regional, localized is the middle, like grayish one, and then distant is the lower one. So these people who are young are being diagnosed with aggressive cancers.
Oh yeah, that makes sense when I think they're not getting screened. They'd like to only present that they have severe symptoms.
Yeah. So for people online, I don't know your name, but you said that it makes sense that they're probably being diagnosed with late cancer because they aren't being screened. That is completely true.
Because they had symptoms, they get screened because it's
yeah. So it turns out it isn't just in that young age group that we're seeing the increase in aggressive cancers. So if you look at this, you can see back in about 2004 to 2014, the most common diagnosis for all people was localized cancer. And that actually was taken over by regional cancer in about 2014. So it used to be regional, we got better, and now we're back to being regional. So some reason we're getting this switch. And this is despite increased screening. So we know more people are being screened, and yet we're getting more regional cancers than before. So that is data from the US. So what is happening here in Utah? It really does look very similar. So happily in Utah, we don't have a huge amount of colorectal cancer, and we don't have a huge amount of deaths from colorectal cancer. So we get bumpy lines, but our lines in general show the same pattern. So you can see in our over 65-year-olds, we have a decrease. our 50 to 65-year-olds, it looks pretty flat. And then in our less than 50-year-olds, we see the increase. So we really do seem to be having the same trend as the rest of the country. Concerning. So I find this concerning, but I do want to put this into perspective, right? So when I showed you those graphs, I didn't show you the x-axis next to each other. And it's because the x-axes are very different. So for men over 65 years of age, they have 200 diagnoses per 100,000 every year. Men 50 to 65, it's 90. And then men under 50, it's 14. So the trend might be going up, but still those people who are younger are a very small number. So it is still vastly a disease of the older population, but it is becoming more and more something that could happen in a younger population. And I also want to just make people, so they don't go into diagnose everyone with colorectal cancer, just put into perspective that these are still quite rare diseases, thank goodness. Irritable bowel disease is between 10 and 15,000 people per 100,000, so very common. Celiac is 1,000 per 100,000, and Crohn's is 21 per 100,000. So all of those are more common than even colorectal cancer. So these are rare diseases, but even saying that, it is a concerning trend, right? Anything that's going up like this in a cancer trend is concerning. And so I think it's useful to be aware of and to look into. So that, of course, may as well ask me the question, why is this happening? And the truth is, we don't really know. There is not really good data yet about why this is happening. There are known risk factors. Family history is a big one. We know you're double the risk if you have a first-degree relative. Inflammatory bowel disease, type 2 diabetes, those kind of medical conditions, we know they increase your risk. We know behaviors like heavy alcohol consumption, smoking, meat, are increase your risk, and decreased activity. But you can imagine these are all factors, but for example, family history should not have changed and affected whether or not people are getting cancer in the last 15 years. So, and if anything, smoking and heavy alcohol consumption are probably going down, and even possibly red meat consumption. So those all don't seem like a good explanation. So really, it is still really out there what it is. Some things that are definitely high on the list of what people are considering is sedentary lifestyle. We know that is definitely very common in our population. And then access care gaps where people aren't coming in to care or don't get the trust in care. We certainly have seen a decrease in trust in all kinds of different science and medical recommendations. Is that affecting this? And then other things that are being hypothesized is it's some sort of toxin, an environmental exposure, a diet change. Certainly, we need more information on this, but right now we really don't know. So to turn back to what we can do about it, this is a slight joke. We should get to the bottom of colorectal cancer. And that brings us, of course, to colorectal screening. So the national survey that we do, the CDC does across the country, asks people in their survey, are they up to date in the colorectal screening? And it turns out 59% of people will say they are. But I would ask the group here, who should be screened for colorectal cancer? Which, it's a small enough group, 40 to 76. 45 to 76. Anybody?
I'm going for
4?
I think ECS is 4.
Okay, yeah, so it is 4, but I think this is what I find problematic when you ask somebody if they're up to date on colorectal cancer screening, is that implies they know when they're supposed to get screened. So I don't really love that data. It makes me a little nervous. So yes, right now the recommendations is everybody 45 to 75. Everyone should be screened, and then between 76 and 85, it's based on sort of life expectancy and other medical conditions. And then after 85, you're free to go home. But that was changed, and not that long ago. In 2021 is when we moved from 50 down to 45. So all of this data where they have people who report they're up to date, I'm a little skeptical. But anyway, with that in mind, so yes, 59% of people who were polled reported they were up to date on their colorectal cancer, but it is really different based on the age of the person who was asked. So people over 75, 70% of them said they were great. But if you look at the other end of the spectrum, people who are 45 to 49, who are supposed to be screened, only 20%. So we certainly see a really different rate of screening on people's stage.
But the word never really came out that good on that. when they changed the guidelines to 50-45, that never been heavily promoted that we should be screening people 45 to 50.
I agree.
Hasn't come out in public health.
I think we have not had a great messaging campaign about that. And maybe that's something well, actually, I will get there. We are doing this. Right? It is the next part of the slides. So yeah, we need to do more colorectal screening, perhaps pumpkin spice or not. So what are the screening rates across the U.S.? You can see these are again people telling us that they had screening. So in Utah, we look pretty good. We're in that like the second to top quartile. When you look at it as an overall for the state, you can see that we are about halfway. So we're probably in the middle state of how good we're screening our population. And so what strategy should we use? It turns out, of course, there's many different ones to choose from. You have the stool-based strategies, the blood testing, the FIT, the DNA tests, and then you have the colonoscopy and sigmoidoscopy and CT colonogram. So what are these approaches? How good are they or how bad are they? So you can see the sensitivity and specificity here. And really, I should mention that the direct visualization tests, they did qualify that those really depend on the size of the lesion. So these are specificity and sensitivities for a fairly large lesion. But you can see overall, the direct visualization is more likely to detect a cancerous lesion. So it is still considered the gold standard to have a colonoscopy. But in public health, we don't like just looking at that. We want to see, okay, are people actually going to do it? And that's where you can start to see a fairly big difference. Only about, a third to a quarter of the people who are sent in for their colonoscopy actually go and get it. Whereas if you send them home with a FIT test or box, it's between 50% and 75%. So people are generally more likely to do these stool-based testing versus the others. And somebody online commented, is colonoscopy really 18%? It must have been one study where people just really didn't want to do a colonoscopy. So it's a range of studies where that was the sensitivity. It must have been, who knows what they were doing at that colonoscopy screen. But that was a range because different studies were put together. But in general, the summary is stool tests are more likely to be done. And also, I think important to consider is both the cost and the frequency. So together, it means what I take away from this is that there really isn't a perfect test. There's many tests that work and that we should be utilizing. So the summary that we from public health are taking is whatever test is right is the test that actually gets done. Certainly, people who are average risk should be given a range of options. They shouldn't be pushed to just do one and then possibly never go in. But at the same time, we know there are people who are high risk who really should be pushed to this more aggressive screening and more sensitive screening.
But even with that stool, that bottom stool, sensitivity is still pretty good.
Yeah, the sensitivities aren't bad. Yeah. I'm impressed by it. Yep.
That's what we're
Right. Yeah. So when I just said we are trying to do activities to express this, well, it turns out it is a group called the One Utah Health Collaborative has taken this on as a mission to improve colonoscopy and actually all colorectal screening across the state. And so their motto for this is connecting Utahns to the right test at the right time. And they have created this collaboration to really try to address both the policy side and the access side to get people in for whatever testing is going to get them the test. So they're looking at all sorts of things like the testing strategies, the reimbursement. They're trying to get out provider education, so maybe we can get more people to be aware that it's 45, and then patient education to make sure they also know it's 45. And so they brought together a very large group to discuss this, and it's been actually quite impressive getting payers together with universities, together with clinicians to really think about like, why is it so hard to get these tests? And what can we do to improve it in Utah?
There was a question in the chat that said, does Medicare really stop at 70?
The recommendations for screening, and I think it was 75, and then 76 to 85 was based on that. So this collaboration has been focusing on this specific topic for a fairly short time, but it's already impressive how much the group has gotten people to agree and work together. So there is going to be an approach where we're going to do universal messaging so that we can have all the different health systems put out the same message and have it so you can see the same thing in St. George as you do in Bear River, and really get people so that they are talking the same way. And then also one of them that I assume everybody would be excited about is find a way to do standardized billing, get a more clear approach to do billing. If anybody is interested, the collaborative is looking for their clinicians to give input. Their next step is really looking at clinical workflow, and so they'd love to have clinicians be interested. So I can put up this number again later in case anybody's interested in involved. So what should you do? I just would ask that you put colorectal cancer in the corner of your mind. Even for younger people, it doesn't need to be at the front of your mind, but should be in the corner of your mind. I think an easy thing to do is discuss red meat and processed meat consumption. It's a win, not just for colorectal cancer, but for a number of different health conditions. And then make sure you connect people to screening and to get them to the screening that is good and they will do. And with that, I will wrap up colorectal. And next, we will go to measles. So I have to admit, when I put out this topic, what was it, probably 3 months ago? I was sure I was going to be talking about measles in Utah. I am just amazed we still have not had measles in Utah, and I don't want to jinx us, but I am just amazed we don't have it in Utah. But that doesn't mean we aren't going to get it. And I think I would be shocked if we don't get somebody coming in with measles. So measles in the U.S. as of May 22nd, because the CDC is now only updating once a week. We have over 1,046 confirmed measles cases. 729 of those are from Texas, but it is spread across 31 different jurisdictions, which essentially is states. I think they count New York City separate, the New York State. The vast majority of these cases, 96%, are unvaccinated or have an unknown vaccine status. As a public health official, I can tell you how hard it is to get people to give you the vaccine status. Unfortunately, these days, people don't return our phone calls. So that's why we have that's combined. And this is not turning out to be a mild infection at all. We are seeing about 12% of cases are hospitalized. Certainly, it is mostly in the older kids. So 22% of kids under 5 have been hospitalized. But even in the older adult population, we're seeing 7% of people being hospitalized. So we are definitely seeing people get into the hospital for this infection. And then there have been 3 deaths, which I have to say I was surprised when one of the first ones was an adult. But it certainly is that we are seeing this have a very significant health impact on people.
I thought all 3 were kids.
No, I think the second one was New Mexico one.
So they get hospitalized with respiratory failure, is it encephalitis stuff?
So it's mostly failure. They don't break that down on the website, so I don't know exactly, but I know just talking to other states, state epidemiologists, it is mostly respiratory failure, and that's what we would expect with this, a pneumonia and respiratory issues. Yeah. So here's our number of cases over time for the measles. You can see we have this big bump February through May, and we have had a decrease in cases over the last few weeks. We would actually say probably the last 4 weeks we're having decreased cases. But I don't think that means at all that we are out of the woods. I think perhaps the reason we're having a decrease in cases is because we burnt through some of the big centers, but now we have just all these little spreading events that are going to continue to give us a lot more cases. And then this is, just to put it in perspective, this is from 2000 to this year. And you can see we have not yet beat 2019, but we are only halfway through the year. And that is the total year for every other year and only 5 months of the year for this year. So I think we are on par to hit a pretty good record for us. But we should look back and realize that we actually are still exceptionally low from where we were. So this is way back to 1940, and this includes, so I think 884 is from, I think that was 2017 or so. So that goes out to 2017. Oh no, it goes to 2020. It's past 2020. So that must have been earlier this year. So you can see, compared to history, we have very, very few cases. And the reason, of course, is because we have a vaccine that is exceptionally good. And happily, the vast majority of our population is vaccinated. And, it says April 29th. I guess that's when it was from. Yeah. So, and I do think, unfortunately, what the media is talking about is so much about the unvaccinated population. And I think it's also important for us to stress, maybe as a clinician to stress, is be like, 90% of Utahns have gotten this vaccine. It is the vast majority of us, and it's actually a minority that is choosing not to. So happily, most of us are protected, but there is the population that is. So what is measles? And I think this is something that I've been trying to say when I get onto the TV, is I try to say it's not a cold, it's not a rats, it's not chicken pox. We heard in Texas they were having measles parties where they were intentionally exposing children to kids with measles to be able to get the kids immune. This is a disease that 1 in 20 kids gets hospitalized. It is not something we should ever do intentional exposure for. So this is a severe disease. And so I've been trying really hard to talk about how it might sound like a rash, it might sound like chickenpox, but it is still it's a significant disease for a large percent of the people who go and get it. So it is a severe illness. And when we look at the numbers of hospitalization, about 1 in 5 unvaccinated people are hospitalized. About 1 in 20 children with measles develops pneumonia, and then 1 in 1,000 will develop encephalitis. So happily, encephalitis is not common, but it is there, and we're up to over 1,000. So we certainly have this. We know that people who are pregnant also can have complications. They can lead to premature birth and also low birth weight babies. And then, of course, the most extreme is death. It's believed between 1 and 3 of every 1,000 children who get infected with measles will die because of their neurologic and respiratory complications. And then the snake attack one, which I find so strange and scary. I guess it's like long COVID, but this is long measles. Even more scary than long COVID is that it's subacute sclerosing panencephalitis. Occurs about 7 to 10 years after the infection. About 7 to 11 of every 100,000 children will have this severe brain complication. It is fatal. So this isn't chickenpox. Even chickenpox, I don't want to have to deal with, but this isn't chickenpox. This is really a significant infection. So where is measles in the U.S. right now? So here is the map from last week. You can see a number of places. I know just recently, Colorado's had a number of exposures. We'll see how dark they get in the next few days. Idaho also had a number of exposures, so we'll see how dark they get in the next few days. It is certainly well spread. The thing that, of course, makes this so concerning is measles is highly contagious. So here's a little linear line of how contagious things are from Ebola and the 1918 flu, which one person will typically infect 2 others, and COVID, then HIV and SARS, then chickenpox, then mumps, and measles wins, where a person typically will infect 18 other people. So this is great disease to spread. And we know it's the kind of thing where you can literally have somebody walk into a classroom, stay in the classroom for a bit, leave, and most of the kids will get it. So this is a highly infectious disease. So what is measles? So we are very happy. We know clinicians are looking into this because we've had a lot of calls in the last few months for measles ruleouts. But it is a fairly sneaky disease where it kind of looks like a lot of other things, especially in kids, like the classic kid and rash and fever stuff. So usually the kids will get a fairly high fever. Well, actually anybody will get a fairly high fever. And then they will have one of the 3 C's, which is cough, coryza, and conjunctivitis. They then can get a K added into that. So Koplik spots, usually a little bit later, which are what they say it's grain of sand on the inside of the cheeks right behind the molars. And then after that, we get the macular papular rash, which is the classic symptom of measles. I would say quite often we see that's when people come into the doctor's office, is when they have the rash appear. This rash is generalized. It usually starts at the hairline and moves down, but we know every rash decides to do something different at least a few times a week. And in terms of timeline, we have about 10 to 14 days between exposure and when the symptoms even start. We then have 3 days. The first few days is when that fever and the 3 C's come out. And then the Koplik spots appear, and that's the prodrome period. We usually have that for 3 days. And then the rash comes on, and it usually lasts for, the rash comes on and can last for a while, but you're most contagious for actually the 4 days before your rash came on to the 4 days after your rash came on. So there is really an 8-day period where you're quite infectious if you have measles. And then people can stay with a persistent cough for quite a while, 2 weeks. And so this is a fairly prolonged course that we see in people. So if you say have somebody come in, what would be the clues suggesting measles? Big one is no vaccine. The vaccine's great. It's not perfect. Nothing is perfect. But certainly if somebody doesn't have a measles vaccine, it bumps up my suspicion immediately quite a bit higher. And then obviously if they've been exposed to someone with measles or an area of measles, which is getting a little complex in the United States right now. But it still is, if they've only been in Tooele and they haven't traveled anywhere and they haven't had visitors from other places, it certainly drops my suspicion down. Whereas if they've been on a plane, they've been to Texas, that bumps my suspicion down. Then we want to make sure they have the right symptom patterns. Do they have that fever in the 3 Cs before the rash, or is it after the rash? Complex spots are actually considered pretty pathognomonic. I think it's easy to sometimes overdiagnose those. And then that would be the big things I'm looking for when I'm trying to figure it out is measles. Of course, there are many febrile rashes in children. As a pediatrician, I remember how many fevers and rashes, and you never knew what they had. But the big ones that tend to be confused with measles is parvovirus B19 or Fist disease, where they get the really, really red cheeks. And that tends to be in school-age kids. There's HHS V6. I never knew it was called 6 disease, but I guess it's 6 disease or roseola. It's more often in the infants. It tends to have a rash more on the trunk instead of starting at the hairline. And the rash is usually, starts before the fever or with the fever, whereas with measles, it's fever, then rash. And then enterovirus, which is hand, foot, and mouth disease. And it does, as its name says, gives a rash on the hands and feet, which is usually followed by measles. And it tends to have a more of an urticarial rash instead, which is not classic for measles. And then last is a drug reaction, which hopefully is a little easier to figure out if they started a drug in the past 2 weeks. So of course, what do we want to do all about this? It is vaccination. So vaccination is quite excellent. So it's MMR is the recommended medication. We know that 1 dose of MMR is 93% protective against measles, whereas 2 doses is 97. And if you want perfection, I'd say that's as close as we ever get in medicine. Right? Like, is there anything better than 97%? Pretty much never. And it is pretty much lifelong.
For kids that are getting hospitalized, so you talked about that clinical course. COVID, for example, was a late hitter. People become symptomatic and they get hospitalized about 7 days. What's the time course with that? Is it happening early? Is it later? So
I think, it probably depends on your population you're working with. So we've heard from Texas that they are seeing kids come in exceptionally sick. So the family knows they have measles. They just don't want to come in and get bugged about it. So they aren't coming in for diagnosis and they aren't coming in for any care until the kid is really sick. And that's when they're seeing them come in. And I think that's just because of what population is being affected. There is one that has a distrust of medical care. And it just doesn't want government involvement. So they wait till the end. So that we've heard that a lot from that whole Texas cluster, which actually includes New Mexico. I think usually it is after it's into the rash period that we will typically get a kid who might need hospitalization. It takes a little while for the respiratory infection to affect the lungs.
Sort of about 3 to 4 days.
So vaccination. We have an answer to all this. It's called vaccination. I don't know if anybody of you have ever played. This was from The Guardian, where they did this little thing where they put in bubbles with all different population vaccine levels, and then they shot balls at it, and it try 5 times to infect the population. If it spread, then they'd have probability of spreading in each one. It's quite addictive if you want to play for like 3 minutes. Pretty fun. So I did it, and this is what 68% vaccinated. It spread pretty well, but these populations that were 74% to 99%. In fact, protected with the vaccine, even though they were shooting measles at it, even though essentially you could imagine somebody flew in with measles, it didn't spread. So that is really, of course, herd immunity in a nice little picture. So what is our vaccine like here in Utah? So our best data on vaccinations is coming from our kindergartners because they have to document their vaccinations or they have to document an exemption. In Utah, it is actually quite easy to get an exemption. So we have quite a few exemptions, but here is our kindergartners with MMR exemptions going from 2014 to 2024-25. And you can see we had a fairly steady course. And then not surprisingly, in 2020, we see that spike. So yes, the red arrow probably is not necessary in this graph, but yes, we are concerned by that recent increase. we really should say that this is an overall picture. It is not telling the full picture because what is concerning is this. So we do have parts of the state that have vastly higher exemption rates. Southwest, unfortunately, really does stand out there with 18% exemption. So you can imagine if we have that little ball of little red dots, different parts of the state, if somebody flies in and visits, it's going to do very different things. And that's quite concerning. So if we map it out, you can see we do have quite high exemption, which means quite low vaccination in a lot of our southern part of the state, which is concerning. You can see Tooele there. You're doing pretty well, actually. I mean, if we want to call 6%, pretty well. Parents getting exemptions. So we actually added a question into the exemption form. I think it was a year and a half ago. It was more sometime in the recent history, where we asked them why they were exemption. It was an optional question. They didn't have to answer it. So it means a lot of parents didn't answer it. But of those who did, we got 243 responses. And the 64% of them, they were saying it was for personal belief exemption, which of course is so broad. Who knows what that means? You can see the yellow is which exact vaccine they were asking for exemptions for. MMR is the fourth one in, so it was just like everything else. It was pretty high.
There's a question that says, how long does it take to build immunity after the first dose?
So when we have somebody exposed, this is where I'm going to have to extrapolate. I had to admit I don't remember exactly, but I think it's about 7 days. We should look that up. I'm not sure. But it is actually quite quick because we know we can give people the vaccine after they've been exposed and protect them. So that shows that it can be a very fast immune response. So what is the main reason? We asked people what was the main reason they were seeking exemptions, and you can see that a third of them thought the vaccine was not safe, and it's vaccines, right? Vaccines are not safe. So in general, most of these people are seeking exemptions. We're doing it for multiples. A smattering of other things. So we asked also where they got their information and that they felt trustworthy. You will see family doctors are number one. I will say I'm concerned that only a third of them think their family doctor is trustworthy, but it is our best bet right now, right? I don't know where they're getting their scientific papers. Internet searches we have pretty much no influence over. So what we can influence is our clinicians across the state. So what if this kid comes to see you? What do I want you to do? Well, the very first thing I want you to do is stop and put on an N95 mask or a respirator so that you don't get infected. I assume most everyone is vaccinated, but we do not want to depend on your vaccination because there's that 3% who will get infected. We would ask you then to assess the patient immunity, see what their vaccine status. Maybe some people have had immunoglobulin tests to document their vaccine status. See if they've had a history of measles. Record their the risk factors. Have they had travel? Have they had somebody come visit? Do they have any known exposures? Review the symptoms, and then ask about new medications and antibiotics to be able to rule things. So if you're still considering the person to be measles, really we would ask you to isolate the patient and contact your local health department and begin the workup. We would also say don't just rule out measles, right? Because we've found a number of times it takes a while to get the measles test back. It's nice to be able to rule something out first. And so we would encourage you to consider doing other tests that test for things that look pretty similar, such as parvovirus, adenovirus. You see the long list. So consider other labs while you're ordering the measles lab. So what do we ask you not to do? So please don't have them then walk back through your waiting room after you said, oh, we think you have measles. Don't have them walk back through your waiting room. Have them put on a mask. Try to get them out an alternative exit, something where they are not exposing other people. You also might want to, if they were in your waiting room in the beginning, you might want to start identifying who is in that waiting room in case we need to give anybody post-exposure prophylaxis. So people who are unvaccinated, babies who are under a year, right? All these people who are at risk. And then please don't send them to the ER without warning, because we want our ER to not have a massive measles exposure. It's one thing to deal with one measles case. It's another thing to deal with the entire emergency room being exposed to measles. So if you're sending them to the ER or to the hospital, please talk to somebody and arrange for them to be brought in a specific way, have masks put in, something to limit the exposure to everybody else. So measles testing, measles PCR is by far the most accurate and easy way to do this. It can be done on an NP or a throat swab. It is something that you need to do while the person is actually mildly early in infection. So if you have somebody who has long-term, like it looks like their pneumonia came on quite late compared to their symptoms, they might test negative for measles. So the PCR is typically positive for about 7 days after the rash comes on. Happily, we have many more labs doing this test than we did even 3 months ago. So most of the big commercial labs are now doing it. We do have the ability to do it at the public health, within public health, but we send it to California. So in general, we recommend you do it through your own lab because it's a lot quicker. But if somebody's uninsured or something like that, where you think it's going to be a big burden to do that testing through a clinical lab, we can arrange testing for you. There is antibody testing, and I know that it's on a lot of like ordering sheets. I generally am not at all a fan of measles antibody testing because it is exceptionally confusing. Partially because it has a lot of cross-reactivity. So parvovirus pretty much routinely tests positive as measles. Makes you all panic. We get to do a lot of work and then we realize it's actually parvo. It's also just a test that has a lot of false positivity. And on the other hand, it also can be negative for the first few days. So if it's positive, it might be false. And if it's negative, you might just be too early. So in general, the antibody testing is not really very useful. So then we ask you, please call public health if you really think you have somebody with measles, or even if you are on the like, I'm worried this is measles, please call us. We have a central line that we can help you with. We will usually work with your local health department, but the state can direct you to that local health department. And then what will we do? If you weren't already able to connect with PCR testing, we'll do that. We will help identify and contact any people who are exposed. So maybe it's people in the waiting room. But it's also people the patient went to school with yesterday or went to Chuck E. Cheese with 2 days ago. So we will work with the patient and your team to identify any other people who have been exposed. We'll help administer post-exposure prophylaxis. So we can give MMR vaccine within 48 hours of exposure, and that's shown to be very effective. And then for people who aren't eligible for MMR, so people who are too little, or who are pregnant, or immunocompromised, we can give IG, either through the IM or IV routes. And that actually is useful up to 7 days after.
So the IPIG, is that readily available? Is that we should think is places like this?
Yeah, so we have a stock at the state. I will say it's not a lot. It's a quite an expensive med, especially for the health department. The U has a number of stock it has it stockpiled. They have some. Intermountain has some. We've identified, my team has a log of where it is across the state. So if you have a case, we will find where you can get some. Yes. Yeah, IVIG I think is a lot more available, right? Yeah, IMIG. And also IMIG, it phases out pretty early because you have to give such a large dose if anybody's like even a reasonable adult size. So IMIG we pretty much little kids. Yeah. And then we also would alert health systems of the possible additional patients so that they are aware that they might have measles coming in their door. So that is my wrap up about measles and colorectal cancer. And of course, I should thank all the people who helped me do this. I am just the hub that gets to come and do the presentation. They get to do all the real work. So both the local health departments and our Department of Health and Human Services, the clinicians who get us all the data, maybe even not even realizing it, and then all the different groups that have done this and people who helped with this presentation. So happy to take questions. Yes.
So when you were looking at the respiratory stuff earlier, so flu, RSV, COVID, is there any talk about putting all of the other viruses that are also floating around? Because since COVID, the viral respiratory panels have exploded in popularity, so we're getting that data. And it might be nice to know what else is floating around in the ether.
Yeah.
Those three.
So the question was, are we thinking about looking at other respiratory illnesses that are on like the extensive panel? Because now we have the ability, the clinics are testing for all these different viruses. So in public health, we try to balance the data we need versus the data that's interesting, right? And we definitely have people who are concerned about how much data we take. So we try to keep focused on the areas that we know we're going to have the biggest impact on. So for that reason, we keep our list of reportable conditions as small as we can. On the other hand, to have something where we could work with, for example, the U, which you're part of, right? Your data goes into. We are very interested in doing that as specific projects where you can look and see like how often are your tests coming through? How often are these things coming? Because we try not to legally require things that maybe are not as actionable.
I don't think like legal requirement, but sometimes it'd be nice to know, hey, listen, these entities are also out there instead of waiting for a 3-hour test to come back. Probably one of these because I'm seeing this spike in the future.
Right. And I think that's something where we do have good relationship with our clinical labs, with UPHL, with like the Intermountain Laboratory Systems, where we do get calls when they're like, wow, we're seeing a lot of whatever. So we get those kind of informal things. I think it is something we'd be interested in. We'd love to have more resources to do.
So
So it's you said that a QR code is the way to go, but 4 QR codes. 4 QR codes are the so I'll start at the bottom here. The public health care minimums. This is what you just saw. Sign up for it so that when we're not here in Tooele, you can see it. You'll just get an announcement. The middle one is our health advisory notification. So this is where we send out really the urgent information. So if there, like for example, when we had our first Mpox case, we sent out information about how to get testing because we knew clinicians were not familiar with that disease. So that is our listserv that we try to use exceptionally sparingly for the emergency things we really want clinicians across the state to know about. The other corner, which is sort of blocked off because the recording thing, is public health updates. That is a more routine email where it is things that we think are useful but are not emergency. So if there's a new resource, a new training, if we suddenly got an investment in our smoking cessation options, we do a little blurb, and that's at most once a week. We don't always send it every week.